Good evening to all of you. I am audible. Raman.
हाँ सर बोलिए ना।
Audible.
Yes, sir. Yes, sir.
Good evening to all of you.
सर स्लाइड शो पे क्लिक कीजिए डॉक्टर दीपक।
Just a minute. Network. We are here to, on the occasion of the second foundation day of the Regional Institute of Ophthalmology, BHU. First of all, we pay our floral tribute बनारस हिंदू यूनिवर्सिटी भारत रत्न पंडित मदन मोहन मालवीय जी. One short brief about this university. Banaras Hindu University is the largest residential university in the Asia, spread over 400 acres, organized into the 6 institutes like Institute of Medical Sciences, Triple IIT, Institute of Management, etc. 14 faculties and 140 departments. Around 3,500 students from 48 countries are enrolled in it. And the foundation was established on the 1916, and in 2016 these are the some tickets and signs released by the government of India on the centenary year of the Banaras Hindu University. This is our gate, and this is Institute of Medical Sciences and Sir Sundar Hospital. Now coming to the Regional Institute of Ophthalmology. Our department was established in 1964 by the present inauguration was done by the late Pradhan Mantri Lal Bahadur Shastri sir, and in 2017 it was upgraded into the Regional Institute of Ophthalmology by our Honorable Pradhan Mantri Sri Narendra Modi ji. This is a small video for the overview.
काशी हिंदू विश्वविद्यालय के नेत्र विभाग को क्षेत्रीय नेत्र संस्थान के रूप में उच्चीकृत कर भारत सरकार ने इस क्षेत्र की जनता को उत्कृष्ट उपहार दिया है।
साथियों, आज देश में रीजनल इंस्टीट्यूट ऑफ ऑप्थेल्मोलॉजी एंड क्षेत्रीय नेत्र संस्थान का भी शिलान्यास किया गया। 54 वर्ष पहले लाल बहादुर शास्त्री जी ने यहाँ नेत्र विभाग सेंटर के रूप में विस्तार देने का अवसर आज मुझे प्राप्त हुआ।
वर्तमान सरकार द्वारा वाराणसी में पिछले दिनों में शुरू किए गए कई महत्वपूर्ण स्वास्थ्य परियोजनाओं की श्रृंखला में ये नवीनतम उपलब्धि है। वर्तमान में प्रतिदिन लगभग 400 से 500 मरीज उपचार हेतु यहाँ आते हैं। वार्षिक आधार पर इनकी संख्या 1 लाख से अधिक होती है। इस विभाग को प्रदेश के मेडिकल कॉलेजों में सबसे अधिक मोतियाबिंद के ऑपरेशन करने के कारण राज्यपाल पुरस्कार से सम्मानित किया जा चुका है। पूर्वी उत्तर प्रदेश, बिहार, छत्तीसगढ़, मध्य प्रदेश, झारखंड व नेपाल के लगभग 20 करोड़ लोगों को बीएचयू के नेत्र विभाग पर पूर्ण आस्था है तथा उनका विश्वास है कि यदि बीएचयू में बीमारी का इलाज कराने आए हैं तो अवश्य ही ठीक होगी।
मेरा नाम कामेश्वर सिंह है, ग्राम मुठानी, मैं बिहार रहने वाला हूँ। मैं अपनी यहाँ पत्नी का मोतियाबिंद का ऑपरेशन कराया हूँ और यहाँ पर जो भी इलाज होता है।
मेरा नाम विनय कुमार सिंह है, छित्तूपुर से हम आए हैं। हमारी माता को मोतियाबिंद का ऑपरेशन कराना था और यहाँ पर बहुत सारी अच्छी सुविधाएं हैं। डॉक्टरों का बहुत सहयोग है। 18 सितंबर को जो माननीय नरेंद्र मोदी जी ने घोषणा किया है उससे मरीजों को और लाभ होगा और पूर्वांचल के मरीज को बाहर नहीं जाना पड़ेगा। इसके लिए नरेंद्र मोदी जी का बहुत बहुत धन्यवाद।
और 18 सितंबर को प्रधानमंत्री ने आँख के हॉस्पिटल को उच्चीकरण करने के लिए घोषणा की है, तो इसके लिए हम लोग आभारी हैं।
रोगियों के इस विश्वास को कायम रखने के लिए इस नेत्र विभाग ने शोध का सहारा लिया। इनके शोध कार्य विभिन्न राष्ट्रीय एवं अंतर्राष्ट्रीय पत्रिकाओं में छपते रहे हैं तथा पिछले 5 वर्षों में 200 से अधिक शोध पत्र एवं 20 से अधिक पुस्तकें प्रकाशित हो चुकी हैं। सरकार द्वारा प्रदत्त कई परियोजनाओं जैसे इंडियन काउंसिल ऑफ मेडिकल रिसर्च, नेशनल प्रोग्राम फॉर कंट्रोल ऑफ ब्लाइंडनेस के कार्यक्रम भी इस विभाग द्वारा संचालित हुए हैं। ग्लूकोमा, कार्निया, भेंगापन व नेत्र के कैंसर इत्यादि क्षेत्रों में ये विभाग विशेष रूप से कार्य कर रहा है। को कई बार लंबा इंतजार करना पड़ता है। नेत्र रोगों के निदान एवं उपचार में आजकल टेक्नोलॉजी का प्रयोग बहुत बढ़ गया है, परंतु ये उपकरण इतने महंगे हैं कि सभी अस्पताल इन्हें खरीदने में सक्षम नहीं हो पाते हैं और मरीजों को दूसरे बड़े केंद्रों पर जाने की आवश्यकता पड़ जाती है।
हम लोगों ने केंद्रीय स्वास्थ्य मंत्रालय को एक रिपोर्ट भेजी स्टेट प्रोग्राम ऑफिसर के थ्रू कि हमारा विभाग को उच्चीकृत करके क्षेत्रीय नेत्र संस्थान के रूप में परिवर्तित किया जाए। इसके परिणाम स्वरूप पिछले 7 सितंबर को हमको केंद्रीय स्वास्थ्य मंत्रालय से यह पत्र प्राप्त हुआ कि आपके इंफ्रास्ट्रक्चर को डेवलप करने के लिए सरकार ने 38.58 करोड़ रुपए स्वीकृत कर दिए हैं,
जिससे इस संस्थान में नेत्र रोगों के निदान एवं उपचार के लगभग सब उपलब्ध होंगे तथा मरीजों का बेहतर इलाज होगा। इस क्षेत्र के लोगों को इलाज के लिए अन्यत्र जाने की आवश्यकता भी नहीं पड़ेगी। इसके साथ ही ये संस्थान उत्कृष्ट नेत्र चिकित्सक तैयार कर सकेगा। क्षेत्रीय नेत्र संस्थान के रूप में उच्चीकृत होने के बाद इस विभाग की जिम्मेदारियां बढ़ जाएंगी। इस क्षेत्रीय नेत्र विज्ञान संस्थान का निर्माण केंद्रीय लोक निर्माण विभाग भारत सरकार द्वारा कराया जाएगा। नया भवन 7 मंजिल का होगा। इसमें 4 नए आधुनिक ऑपरेशन कक्ष होंगे। विभिन्न परीक्षणों के लिए विशेष कक्ष होंगे व प्रतीक्षारत रोगियों के बैठने का पर्याप्त स्थान होगा। नए डॉक्टर्स की ट्रेनिंग के लिए वेट लैब, वीडियो कॉन्फ्रेंसिंग कक्ष इत्यादि की सुविधा उपलब्ध होगी। सरकार द्वारा धन उपलब्ध कराए जाने से हम सभी आधुनिक उपकरणों को खरीदने में सक्षम होंगे, जिससे रोगियों को सस्ता व आवश्यक उपचार यहीं पर संभव हो सकेगा। रिफ्रैक्टिव सर्जरी, रेटिना की सर्जरी तथा अन्य अत्याधुनिक सर्जरी की सुविधाएं अब इस संस्थान में दक्षता के साथ उपलब्ध हो सकेंगी। संस्थान के रूप में विकसित होने से हम गुणवत्ता परिवर्तन तो कर ही सकेंगे, साथ ही बड़ी संख्या में लोगों की सेवा करने में भी सक्षम होंगे।
Thank you. The chief guest of the today function is Professor D.K. Shukla sir. He is the rector Banaras Hindu University, former director, medical superintendent, and head of the department general surgery IMS BHU. Sir has done his MCS from the University of Wales and honored with many awards and oration. Also the fellow of wound care specialist from the Malaysia and the National Academy of Medical Sciences. Sir has published many international publications, around 500, and 4 books and many chapters. Welcome, sir.
Thank you. Am I audible?
Next is our chairman, Professor M.K. Singh, sir. He is the Chief Regional Institute of Ophthalmology and Dean Banaras Hindu University, BHU, Varanasi. Welcome, sir. Today we have 3 prominent national and international guest speaker. First one is Professor Mangat Dogra sir. He is the Director Retina Services, Grewal Eye Institute, Chandigarh, and former Head Department of Ophthalmology, PGI, Chandigarh. Sir has published more than 200 publications and many books and chapters. He received many national and international awards, and important few are Himachal Gaurav Award, which is the highest state award by the Himachal Pradesh, and the Achievement Award by the American Academy of Ophthalmology. Welcome, sir. Our next eminent speaker is Professor J.S. Tetiyal, sir. He is the professor and head cornea refractive and cataract services at RP Center, AIMS, New Delhi. He awarded Padam Shri for his outstanding contribution in the field of medicine for the ophthalmology. He received more than 30 orations and many awards. Important one is the achievement by the American Academy of Ophthalmology. Sir has published more than 400 articles in international and national journals, 4 books, and 52 chapters. Our third speaker is Professor Rohit Sethi, sir. He is the Vice Chairman, Narayan Netralaya, Bangalore. He is a clinical and translational scientist at the GROW Laboratories and faculty at Department of Ophthalmology, Maastricht University. More than 200 articles and prestigious Colonel Rangachari Award by the All India Ophthalmic Society. Welcome, sir. We also have in the panelist Professor O.P.S. Moria, sir, who is head of the department, Professor V.P. Singh, sir, Professor Prashant Bhu, Sir R.P. Moria, sir, and myself as today moderator of this webinar. Thank you, sir. After this, I would request M.K. Singh, sir, to welcome all the speakers for his welcome speech. M.K. Singh, sir.
Yes, yes.
For your welcome speech.
Thank you, Dr. Deepak. Thank you, Dr. Deepak, for giving me this opportunity to speak as a welcome address. Today we are celebrating the second foundation day of the Regional Institute of Ophthalmology, Banaras University. I welcome all the participants who have joined us in this webinar. In the series, first I would like to welcome our chief guest, Professor V.K. Shukla, sir, who is the rector of the Banaras University and former director, Institute of Medical Sciences. He has been very instrumental in the creation and the establishment of the Regional Institute of Ophthalmology. And even today, he takes keen interest in the day-to-day development of the RIO, and he pushes us forward for the better refinement of the upcoming institute. I welcome Professor Mangatram Dongra, a well-known vitreoretinal surgeon of this country and former professor and head of the department at Advanced Eye Center, Chandigarh. I welcome Professor J.S. Titial, who needs no introduction. He has a high and strong bondage with Banaras University, and whenever we invite him for any examination, for his speech, anything, he is always ready to come to the Varanasi and joins us. I welcome you, sir. I welcome Professor Rohit Sethi, who is doing a commendable work in the field of dry eye and refractive surgery. We welcome you in this webinar, sir. I welcome all the participants, the alumni of our institute, my seniors and juniors who are participating in this webinar, and their cooperation and joining this webinar will be a strong stimulus for us all to achieve the goals and objectives of the upcoming Regional Institute of Ophthalmology. I again welcome you all, and I hope that this webinar will be very much beneficial for all those participants. Thank you very much.
Thank you, sir. Now I request our rector, sir, Professor V.K. Shukla, sir, to give us blessings on this occasion. Shukla, sir, please.
Thank you, Dr. Deepak. Good evening to all. I am happy to be with you all this evening on the auspicious occasion of second Foundation Day function of Regional Institute of Ophthalmology, Institute of Medical Sciences, Banaras University. It gives me immense pleasure to welcome esteemed guest faculties, Professor Mangatram Dogra, Professor John Singh Patial, and Professor Rohit Sethi, dear participants, ladies and gentlemen, to this webinar. As you all are aware, this National Program for Control of Blindness was started in 1976 with the aim to bring down the prevalence of blindness target to 0.3% by year 2020. And you'll be happy to know that India is the first country to initiate this program way back in 1976.
As you all know, cataract and refractive errors are the two main causes of blindness, constituting more than 80% of the total causes. The idea of creating the Institute of Ophthalmology in Varanasi is to strengthen the strategy of NPCB, that is eye health for all, and prevention of visual impairment through provision of comprehensive universal eye care services and quality service delivery to 20 crore population of 7 states and 1 country, Nepal, coming to IMSBA for healthcare. I feel that emphasis should also be given to create teleophthalmology center at PhD level to ensure delivery of best possible diagnosis and treatment of eye diseases in remote area and offer community awareness on eye care and stress on preventive measures. I am sure that all of you are merchants of light and knowledge and are in a position to save the vision and restore the sight of countless number of blinds or nearly blind who otherwise are doomed to a life of misery and darkness. I hope this webinar provides opportunity to young ophthalmologists to interact with the renowned faculty. I wish this webinar a great success. Lastly, I would like to congratulate Professor M.K. Singh, Dr. Deepak Mishra and their team for arranging this webinar. And I also thank them for giving me this opportunity to be with you this evening. Thank you. Jai Hind.
Thank you, sir.
Thank you, sir, for your blessings. Now, I request our first speaker, Professor Dogra sir, to start his talk on the retinopathy of prematurity, ROP.
Sir, you have to unmute yourself. We can't hear you.
Oh, sorry. I'm sorry.
Again unmuted. Yeah.
Yes.
Start now.
Yes. Thank you, Professor Tetial. You are a savior. Respected Professor Shukla, Director BHU, Professor M.K. Singh, Chief of RIO BHU, Dr. Deepak Mishra, other faculty colleagues and panelists, as well as two of my friends here who are guest speaker, Professor Jeevan Tetial and Professor Rohit Shetty. I'm very fortunate to share the stage with two very eminent ophthalmologists as well as the scientists in the ophthalmology in this country. I must thank especially Deepak Mishra, who has given me this opportunity to be part of this celebration of the second Foundation Day of RIO BHU. I think already he has shown that little clip that how historical the BHU is. The name itself carries such a importance for all of us in this country, as well as it has done remarkable job in training people for so many countries, not only our country. So thank you very much. And I'm going to talk and share something today on this Foundation Day on a subject which has been very dear to me all my life. I think our last 30 years I did this work in this country. And I thought I'm going to most focus on the Indian scenario as far as the retinopathy of prematurity is concerned. You see, if I make call, and some of our elderly senior Professor M.K. Singh is here and Professor Tetial, they would know it. It would come in earlier days when we did our PGs as a retrolantar fibroplasia as differential diagnosis of retinoblastoma. And that used to be one paragraph somewhere, and it was gone. And nobody thought that this disease is going to become so important for a country like ours, which is a developing country, and it is becoming one of the major causes of childhood blindness. And this is a new and emerging cause, and we have to learn so many things about it. At this time, large number of babies in our countries are presenting late with bilateral irreversible blindness where nothing can be done later on. And this is happening because there is either no screening or delayed screening for ROP, and the treatment is available hardly at very few places. I am very fond of projecting this slide, which has been given to me by our friend Claire Gilbert. I think this is a remarkable slide which shows that if the infant mortality rate is low, like in all the developed, this green world, then you have a very low ROP blindness. Why? Because they have excellent neonatal care and screening programs. But in case there is a problem with the neonatal care as well as the screening program are not adequate, like where we are now, we are all in red. So most of the world is in red. You can imagine that. So here, there is a high risk of ROP blindness. I think when we were students, even some years back, we were in black, like all this sub-Saharan area or African area is, because here the babies are not even surviving. And that is what was happening in India. And now they are surviving with better technology more and more. And we are getting these blind babies. That's how we have to be learning more and more about this disease. You see, India accounts for the maximum number of preterm births in the world. That is 3.5 million. And 60,000. And the 6 lakhs are below 32 weeks of period of gestation. That means these are the ones which would require to be screened. And 2 lakhs are at risk of developing ROP. And 20,000 develop sight-threatening ROP. Out of these 20,000, many are going irreversibly blind. But in addition to this, the problem which I am going to focus and which has been the major part of our work from PGI Chandigarh is the higher birth weight babies, 32 to 36 period of gestation babies developing ROP. So we have a much larger number, higher number of babies, those who are developing ROP. I think we did the first prospective study in this country along with Dr. Lingam Gopal's study. This was in 95 when we published back to back. And we could see the incidence was almost similar what was in Western countries and what is still there. This is the last one, Hungi et al. Has been done by Anand Vinekar, where it's still almost closer to what we had seen way back when we started this work. The problem with ROP screening, which I talked right in the beginning to, is we do not know which one would develop sight-threatening ROP among the premature infants. That's the challenge. So this is not a congenital disease. Premature child is not born with ROP. Screening aims to identify treatable stage. And there is a small window for screening and treatment. That's where I think we have to concentrate ourselves. The delay cause either permanent irreversible blindness or severe visual impairment. And the biggest problem is medico-legal implications. Many of you are aware the highest awards which has been given are in the ROP problem related by the Supreme Court and other. They are going to many, many crores. And you can imagine the economic and social burden of childhood blindness is immense. And you should also understand that they get one child which is born premature after losing so many, because they are all high-risk pregnancy. That's how the child is born premature, and that also is totally blind. We did get together, you can see these names here, Subhadra Jalali, Hashma used to do earlier ROP, he is glaucoma specialist now, and then myself, Professor Azad, Lingam Gopal, we got together sometimes way back in 2003, we published first time, and we looked at that how it can be done. But what we realized soon, and that was that the screening guidelines which are being used in the Western countries are not what we should be following, because we will be missing a lot of babies. And that is what here, this is the thesis which I had given to my most famous student, Dr. Anand Vinekar, when he was with us in PGI. And I must share with you here, you will be surprised. This is one paper which is among the 10 best papers, which is 10 best papers cited by the IJO. Whenever you open for citation, IJO, it will come up. And it has already got close to 200 citations in Indian journals. You can imagine that how important it is, because this is why it is important. He did as his thesis that 16% of the babies were more than 1750 grams. Imagine so how many would have gone blind if we followed 1500 grams, and 6.5% were even more than 2 kgs. And 23% of the babies had a period of gestation even more than 32 weeks, which was a cutoff earlier in the Western guidelines. So you can imagine how important this study was, which Anand did as a thesis. So these are the American guidelines presently, which are being followed, 1500 grams and less than 30 weeks. And we have now, with great difficulty showing this data, ultimately convinced the government, and these have been notified. It is now 2000 grams, 2 kgs and less than 34 weeks of gestation. That is what need to be screened. So everybody in that group need to be screened. We need a single nodal person to be identified in our hospital, which should be part of the pediatrics or neonatal team, who would communicate with the ophthalmologist and parents. He or she would identify the babies for screening and combine the visit of a ROP screening in your center with the follow-up of neonatal problem. They can't come twice. That is very difficult for them to come 2 times. And the record keeping, signing, even writing time when they have to be sent is very important. That also has medical legal implication. The important part to remember here for all the alumni and others, those who are part of this today, that the first screening must be done before 1 month. So 30 days is sacrosanct. This Tees Din Roshni Ke has been given by Subhadra Jalali as a slogan. So it's very, very important. If we delay, perhaps then it may be too late. The initial screening, even if you perform it early, should be done in your NICU, SNCU, nursery area. Why? Because then you can talk to the parents. You can emphasize, otherwise they don't understand. You have to really tell them this is a blinding disease. If you don't bring back the child, maybe there is no sight, and later on even eye can't be sort of replaced. They feel that eye can be replaced here. No, there's no transplant when the retina is totally gone. Later, of course, you can do in the clinic in the OPD area. Any ophthalmologist who is well versed knows about ROP and indirect ophthalmoscopy. I think I must request here, even all of you here in BHU must tell all your students to buy a indirect ophthalmoscope. You see, it's very important. These days, in good centers, like RP Center, like our center in PGI, everybody buys the indirect ophthalmoscope, because indirect ophthalmoscopy is so important for every disease. If you don't do indirect, you have not seen more than 30% of the fundus. You have never seen the whole retina in life. And otherwise also for many diseases, that is what you require. Of course, these days, rat cam screening or a wild field screening with the indigenous camera is coming up, because this is also important. I think this may take up because Anand Binekar, who's in Narayan Netralaya, and Dr. Shetty has really supported him. He has sort of established one of the largest tele-screening center, which is spread all over Karnataka. And it is a model which is being followed by not only so many states in India, but so many countries now. And his work is remarkable. And now he's trying this with the indigenous camera, which is much cheaper than rat cam, and that is giving also the similar results. So what are the current treatments? The close monitoring of oxygen saturation level. I put it here. I think here there's a big problem. I'll talk later about giving the 100% oxygen. And the peripheral retinal laser is the gold standard. And anti-VEGF injection, everybody is fond of giving shot these days. And the vitreoretinal surgery is stage 4 and 5. So laser treatment must treat, never, even if the baby is stable, never treat in your own hospital just like that. Treat in NICU or in operation theater where you have appropriate monitoring, where you may have an The laser treatment is delivered through laser indirect ophthalmoscope, and it is a confluent laser, and 90% would attain a favorable outcome. If you do a good laser, 90% of them you can save, and in timely. I think for the first time in the world, we had done the laser treatment through the wall of incubator for a very unstable, where the neonatologist won't allow us to bring out the child, and we published this. And this was in fact done more and more during Corona time, because people were afraid of directly. So they did through the wall of incubator this procedure. They even kind of adopted this method, and this is one such baby done through the wall of incubator. One of the, I think we feel very good about it, because we initiated this, that we are a country which is developing, and we have only one laser, mostly a green laser, which does all the jobs. That is, all retinal jobs are done by that. So previously it was mandated by the Western countries that you will not use anything except diode laser. I think we did this publication in BGO 2010, and that created a lot of confidence among people. Now, of course, we have published recently, as well as there are a few more publications from other centers. Now, you could use the same laser, green laser, with equal efficacy and safety. And that is what is being done by the whole developing countries now. And it is changing even in the developed world. Otherwise, it was such a difficulty. Then I remember how to get first diode laser in PGI way back when I could procure it in 1996. So this is done, the laser with the, you see, it's a beautiful treatment. You can see these vessels, how they straighten up. This is just after 3 weeks of treatment. The vessels have straightened up. The disease has gone. That is what is important here. And we did get together again, some of us, Dr. Subhadra Jalali, Professor Azad, and Lingam Gopal, Narendran, and others, where we have written about the technical aspect, how the lasers should be performed, how we can do it under topical anesthesia, because it is not possible for our country, and it can be done in NICU just under monitoring. And one of the problem in our country is we get mostly from outside the center, most of the center, aggressive posterior ROP. This is seen in 40 to 50% in India. And this is the commonest problem, and this is a more serious problem, more serious disease. It directly goes to retinal detachment without going into any of the stages. And we have a first publication on this in Retina in 2009, and subsequently landmark publication from Arvind Eye group in 2012. And we also publish many more subsequently. I want you to look at where we are in this country. You see, this is from Japan and USA. Look at the tiny babies, 6 to 7 gram babies developing APROP, and very, very small gestation, 25, and we are 1500 grams baby developing APROP. And look at the gestation going up to 32 weeks. So that is where our care is. Our care needs a lot of improvement. And if we go there, that's how we'll bring down the incidence. The problem is the laser treatment is also, it will have 25 to 30% unsuccessful outcome in aggressive posterior ROP. And this we had shown way back that time. And what are the risk factors for retinal detachment after in these very aggressive posterior ROP? This also we published in American Journal in 2013. If it is a posterior zone 1 ROP, APROP, or you have a pre-existing fibrovascular proliferations, or any of these things, they will develop into retinal detachment. So we have to be very closely monitoring them. We also describe one new entity, hybrid ROP. I used to write on file mixed ROP. Finally, when Gaurav Sanghi was with me, he said, "Sir, you have written on so many files this." I said, "We are seeing something which can't be fitted anywhere in the international classification," which subsequently has become known now as a hybrid, which this I had named as a hybrid. I thought it is somewhere in between. And this is something like this. It was not never described. Large loops and something as if it's stuck on the retina. And this has become now known all over the world. And I feel good about it that we described it. And this also, this is first time. We posterior zone 1 ROP or zone half ROP. This is the first exclusive publication which we did only recently in 2019. And what is important here is that laser, 79% of the eyes had unfavorable outcome. So this was our biggest problem. So that is what need to be done with a different kind of approach with combined treatment. Like this, hardly, the blood vessels are not there. They are stopping here and they are just up to this place. This is the posterior. So despite good laser, you can see the retina is contracted. There are stretch breaks, nothing can be done. So that is what happens if we just, so why do we need anti-VEGF for ROP? That is what you would be interested. Laser has high rate of successful finite outcome. If we can do laser, we should do laser only. But zone 1 and APROP, as I said, are less responsive to laser, so they need anti-VEGF. So sometimes the disease may progress despite laser, or you have a lot of vascularity where before surgery you might inject. And rescue therapy where ophthalmologists are not able, this is being used as an excuse, even for cases where probably injections are not required. Because the injection is easy, they will give it. So that is not done. It can be used as a monotherapy or combination with laser. And I already mentioned about other two things. The combination treatment of ROP is for APROP and zone. That is what I am saying. Here we need to do combined treatment. That is how posterior zone 1 ROP would also be helped. That if we do that, that means we give injection followed by laser. Most of them, they would regress. Even despite that, if progress, you do early surgery. And I must mention here a recent publication. This is by Parija Chandra et al. From RP Center, where he has given before surgery and shown excellent results. This has just in January issue of Pediatric Journal of Ophthalmology this has been published. Anti-VEGF and laser in ROP, so I would say now it is getting more and more acceptable, especially for APROP and for ROP in zone 1. The problem is there are late recurrences. There are adverse. If you give anti-VEGF injection, be prepared to follow them closely for a very long time, because many of these retina, they never get vascularized, or you laser them in time. So what are the current surgical approaches? Lateral buckling, lens sparing vitrectomy, lensectomy and vitrectomy. The indications are stage 4A, 4B, 5. Progression despite your laser treatment. Sometimes there's bilateral vitreous hemorrhage or bilateral cases. So case may be like this here. And in 4A and 4B, we have a lot of publication here from our country, especially two of these. Dr. Gadkari is not even there. He's no more. Such a great surgeon from Pune. And this is by Praveen Sen et al. From Shankar Nitralia recently. And you can see this case where we had to do lens sparing vitrectomy. It progressed immediately after laser, like this, became 4B. But if you do surgery in time, I have designed a new surgical approach. This is a nasal LSV, nasal lens sparing vitrectomy. This has been, I'm very happy to share with you that this has been accepted in Retina Journal this time in May, ahead of the print. And this is something which is absolutely new, and maybe it will be taken up by so many people. Why it is new and what is important is, I'll not go into detail of the surgery because that is not the purpose here. But you see what is done here is, what you're going to see is that you put this cannula, you sit on the nasal side and put infusion cannula right in the center. Right in the center. Otherwise, infusion cannula is always put on the side. And this is for all 4B cases. Why? Because the entire retina is attached to the lens on the temporal side. If you don't do that, you will have to remove the lens. The preservation of lens is very important. I hope this procedure should become accepted worldwide, and it is being done by more and more people. This is some innovation which has come from our center, and you see, you can have a very good result even in a case like this. You will see this case, how bad it is inside, how the retina, this is the retina inside, contracted. This very case, I'll not go into the entire surgery, how it is done, here. And this is, of course, intraoperative OCT along with how lifted it is. And I'll just proceed further here. This is the same case, same retina. With a nasal vitrectomy, it has gone back and we could save this child from going totally blind. So management of stage 5 is lensectomy, vitrectomy, and reattachment is only in 1/3 of the cases. We don't want to let them go here because the functional results are extremely poor. So you have to do it before. Preferably do laser anti-VEGF before. Catch them at 4A, 4B, but 5 is a problem. Don't let them go there. There is a third epidemic of ROP blindness in the country, and this is because of the variable quality of neonatal care, lack of screening programs, and lack of trained ophthalmologists. And the oxygen is being used unblended, unmonitored, 100%. So we get a lot of babies. This is not, my friend, cataract. This is retina behind the lens. Now nobody can do anything for this baby. This baby is blind forever. So that is what is the problem today. So this is what we published. We got all these kind of babies and their records, and people have published in ophthalmic epidemiology. Can you imagine? Just look at this, that 50% babies were more than 1,500 grams. The median age of presentation to us was 7 months, and 86% were never screened for ROP, and they came at stage 5. And 74% were self-referred when parents realized their child is not seen. That is where we are. Similar study recently done from RP Center by Professor Azad and Parijat Chandra and others. 89% were never screened for ROP. Similar, 86% babies referred by the ophthalmologist and 8.7% babies referred by the. So you can see this happened even in a city which is like a metropolitan city like Delhi. And 91.3% of babies among them were irreversibly blind. So possible reason for the ROP epidemic is highest rate of preterm birth, use of no blenders, 100% oxygen, and very few pulse oximeters. Lot of SNCUs opening in every district. All my friends, those who are listening to this, you will have to screen for ROP. At least you will have, definitely, because SNCUs are in every district of the country. And the lack of trained among pediatrician, nurses, as well as ROP screening. And even if the treatment is done, it is inadequate. So we need to provide more blenders, train more doctors and nurses, as well as disseminate knowledge about the oxygen saturation. We have to conduct good research relevant to our country, which would look at the factors, how we can bring down this incidence. Then we need good ROP screening and treatment program. Include ROP in curriculum of undergraduate and postgraduate and make it as a major subject now. It is going to be, I can tell you, you will realize it tomorrow that this would be just like you teach diabetic retinopathy. So educating parents regarding ROP, you need a ROP registry for nationwide database and develop national guidelines, which we are trying. So anybody whose child is born, we have some technician, nurse, they should, anybody who is less than 2 kgs, they should put some kind of a band here, and that child need to be screened within 1 month. That is very, very important. So responsibility will, this was also, I gave this as a sort of a task to Anand Venekar, who did this as a study and later published. So what should be done? Even in your make wall charts, just simple printouts from the computer, when to screen, how to dilate in NICU, SNCU, nurseries and OPDs. I would like to just tell you, today we have a IROP Society of India, and all the prominent, you can see, you can recognize so many of them here. They are part and parcel of the group here. And I'm thankful. We are a team, along with Professor Amod Gupta, who was teacher to both of us, me and Professor Jagatram. I think we had a team at PGI for 35 years. We could do many things just because we worked as a team. That is what I would like to say. And there is also something to do with my institution, PGI and ROP. You know, all the ROP experts here, this is Lingam Gopal and Subhadra Jalali and Anand Venekar and me, all are from PGI. They were all all did their residency in PGI. Maybe something to do with this. So I just thought I'll share with you this. So friends, in conclusion, I would say ROP blindness is preventable in majority of babies. Higher birth weight babies develop severe ROP in India. Screening is most important to identify treatable ROP and manage all treatable ROP promptly with laser. That is what is important. Use anti-VEGF in zone 1 and AP ROP only, not in others. Lens-sparing vitrectomy. If people can do somewhere, even one center in a state, train somebody for this. This is not difficult. It is possible, and you can give excellent result. Vitreous surgery in stage 5 has dismal outcome. We don't want to let them go to stage 5. Major problem is suboptimal neonate care and delayed screening. So friends, with this, I think I have taken a little more time, but I'm so passionate about this subject and I want more people to take up this. And I once again thank Professor M. Singh and Dr. Deepak and for inviting me to the Second Foundation Day. And thank you very much.
Thank you, sir, for a wonderful talk.
Thank you.
Thank you, sir. Sir, there is one question for you from one of the Facebook viewer. He want to know, can you tell us what are the things Dr. Anand Banekar are seeing in the tear to check the ROP? There is some study he is saying that examination of tear film for the ROP finding or for some thing.
Well, I think that is just a preliminary study at this time. So there is no conclusive results. They have lot of, I think even Professor Rohit Shetty is going to be here. It is his brainchild, especially the tear being, you see, sort of they study tears in detail in every diseases. So Anand also found some very encouraging results, but it's not something which can be done at this time on the basis where we can really say that if you do tear examination, you will get immediate results. But maybe in future, they are still working on it. We'll have some more data coming in, and maybe at that stage we can say definitely that we can use tear as a part of the entire examination process, or maybe for early detection of ROP. Yeah.
Okay, sir. Sir, like you are knowing, I am going for the PG examination forum and lots of PG are watching you. There is one question from my PG from the Karnataka. She wants to know, sir, what is your tip to how to do fundus examination in a children? Because in a newborn, they are so much clumsy, or everyone even fear to touch them. So any your tips to examine them?
I think I'll tell you one thing. The easiest examination is of a premature child. The premature child is just lying there, not resisting, not doing anything. And you don't even do anything. You can just prise open the lids of this little child and have a peep in with indirect ophthalmoscopy. You can even just rotate the head, may not put even an eye speculum in the beginning. You may not need to put an eye speculum and depression in all. I can tell you that. Most of us, we don't do that in all cases. If it is required, then only you'll need to do that. So it is the easiest examination. It is only the fear somewhere in you. And what I would say, and would like to emphasize all PGs here, learn indirect ophthalmoscopy. This examination is the easiest examination and the most satisfying examination you will find. It's not difficult at all.
Okay, thank you, sir.
Thank
now
you.
Next speaker is Professor J.S. Tetial, sir. Kindly share your screen.
Thank you, Deepak, for the invitation. सबसे पहले तो मैं आप सभी लोगों का अभिनंदन करता हूं इस इवनिंग का, और मुबारकबाद देता हूं पूरे PHU टीम को उनके सेकंड फाउंडेशन डे के ऊपर. और I appreciate Dr. Sukla being there, GS, Dr. M.K. Singh is doing such a wonderful work, and entire faculty of BHU, especially the ophthalmic department, they worked so hard to bring up to this stage to get into RIO. And I hope that आप लोग बहुत अच्छा काम करोगे जिससे कि पूरे भारत देश को आपके ऊपर गर्व होना चाहिए क्योंकि आप लोगों का डिपार्टमेंट there is there, and I am sure young people like Deepak, other people will do wonderful work for the future. And I have a deep respect for Professor Mangal Dogra. He's done a wonderful work in PGI, and he's such a nice person, a very good friend of mine. And I wish him all the best for whatever he's doing now also after retirement for PGI. And his work in ROP is, I think, one of the most looked after by retina people across the world. And what we heard today was wonderful as such. And definitely Rohit being another good friend, been listening to him, his research work. As a mentor, he's done such a wonderful work for the country, for the young people. And today I have been given a responsibility to talk about something, new technology or a new aspect looking into a surgical area of cataract or an anterior segment cornea refractive surgery wise. Whenever we talk about refractive surgery or anything, it all depends where you are placed and what all things you have to look into so that you can do a better job. As in the video shown by Dr. Deepak for BHU, instruments are there, but you got a human being to handle those things to achieve something better. So I would always remain indebted to an institute like All India Institute of Medical Sciences and my team in RP Center who has helped me and my patients and my young colleague, Dr. Manpreet Kaur, who's done a lot of work with me to establish some of the good publications in this field of anterior segment surgeries. And nothing less than RP Center being the place where we learn everything. And I know that it's not me. I have two hands, but we have produced many, many hands through RP Center, through our education and teaching. So that is how we're going to improve the number of people in the highest quality service provided to our country. Let me come to my basic talk today on intraoperative OCT. How does it help in surgical aspects during the surgery of anterior segment surgery? That is corneal surgeries, cataract surgery, and refractive surgeries. So this is basically an in vivo optical biopsy of entire ocular structures, which gives a cross-sectional imaging of the tissue which you are going to see. So this will help in a diagnosis on the table and may give you some clue to plan your surgery or change your surgical decision as per the visibility, the dynamics of instrumentation and the structure you are seeing. And you can do a close monitoring of every step of surgery so that you achieve a good result out of whatever surgery you are doing. See this picture. If you focus only on this, this is what you see. But if you have an OCT attachment, this is what you're going to see. The entire plaque of posterior polar cataract, the intact capsule can be visible, which is so difficult with the microscope as such. See this picture of another case of a posterior subcapsular cataract. See this linear line here, which doesn't tell you anything. But if you have OCT, I know that there's a defect in the posterior capsule and posterior cortical area. So this was a patient who had received intravitreal injection. So you have to be so sure that you're not going to further damage the ocular structure while doing cataract surgery. What about corneal surgeries? This is the incision of cataract surgery. You can assess the incision of cataract surgery right from the step 1 to the end of her surgery and see what has happened. This is a major change which we have seen in a corneal surgery, especially the lamellar procedure. We do endothelial keratoplasty, and we could tell the world that what you have to do by seeing what is happening inside the anterior chamber. See, this is the eye, and under microscope, nothing visible except for air bubble. But see here, the graft is not attached. But after some time, with manipulation, the graft is attached. So this tells you what you have to do on the table. But classically, I think one of the major thing which I have seen here is in cataract surgery. You see only this, you can see a capsulation being done, but you are not sure what is happening here. A tsunami of pressure building from intralenticular pressure, pushing all the cortical fibers, which are going to be, causing the extension of a tear to periphery. This is not visible. This picture, the hill is not visible here. So this only could be seen in an intraop microscope. So what is important is seeing the things that changing accordingly. So what is the principle behind optical coherence tomography? We all know it is based on a low coherence interferometry, based on a Michelson interferometer. The time, delay, and intensity of infrared light reflected from the tissue or structure against the reference beam. So this gives an interference pattern which leads to a cross-sectional image of the tissue of interest. There's a multiple A-scan picture combined into a composite two-dimensional image in the B-scan format. So as far as intraop OCT is concerned, we have had a portable OCTs before we had a microscope integrated OCT. They both have their own advantages and disadvantages. Portable definitely will have more movements while you're taking a picture. It doesn't give you actual surgical dynamicity when you're actually doing surgery. While microscope integrated OCT gives you a picture on the table through your oculars, surgical microscope oculars, you can see both the things together. So you can manipulate accordingly. The major problem with these OCTs are metallic instruments. They block the OCT imaging. So that can create problems sometimes, but they can show many things. So these are basic commercially available OCT which you have in the microscope. If you look here, we have a Harkstide IOCT, we have a Zeiss V-Scan 700, or you have a Baptizen high definition OCT also. They all have wavelength of around 830, 840, 860. They'll give you around 35,000 scans per second, and the depth appreciation ranges from 2 to 2.5 millimeters, and the resolution is around 5 microns for all these cases. So they are one of the highest definition available OCTs attached to microscopes. Let me take you through what all things we can do with this in terms of anterior segment surgery and decision making as such. The application would be for keratoplasty surgeries, ocular surface disorders, glaucoma surgeries, cataract surgery, refractive surgery, pediatric cases, and cross-linking of cornea. So this is what we recently published in a survey article where we incorporated all the articles being published in intraop OCT attachment services in the field of anterior segment surgery, and you'll appreciate major work is from our center only, which will give us idea the real-time visualization of ocular structures during surgery. What do you understand what is happening when you do a particular step for surgery, and does it make a difference in a surgical decision as such? The first thing was, if your IOCT, this is attached to a system where you don't have micro calipers, which you normally see in an anterior segment OCT, which is not there here. So we have a V-Scan 700. The first thing we did, how to calculate the measurement wise. We appreciated that the V-Scan callistroscopy is 265 millimeters or 26 centimeter. The highest depth acquisition OCT is 2000 microns. If you calculate this magnification factor, it comes out again 7.5 microns or 7.5 times. 1 millimeter would be 7.5 millimeter. If you multiply, you're going to get the accurate assessment of a high depth object. So this was our first publication on looking into how do we measure the area of concern in IOCT microscope. So we did on a ICL surgery. We acquired this image. This is the anterior lens capsule surface. This is the ICL. So we could measure this distance from an anterior lens capsule to the posterior surface of ICL. And this was one of the first publications where we could see the ICL on the table and know what is a bolt in these cases. Subsequently, we applied to penetrating keratoplasty. It has an application beginning of surgery, during surgery, and towards the end of surgery. All steps can be seen. There have been two major publications and studies. First, a pioneer study, which is basically done with the handheld OCT systems. Discovery study, which is based on an integrated IOCT in a microscope. If you see here, they had almost 99% of cases they could see the structure of concern. The surgical approach, because they could see better with these IOCT assessment. And if you look into lamellar keratoplasty anteriorly, they'll help right from the initial needle or incision which is being done in the cornea to actual achieving the surgical result as so IOCT is really helpful in all cornea surgeries. Let me show you a little bit on a deep antilamellar keratoplasty. This is the surgery before I had IOCT with me. So here this is the case of keratoconus. You can see here we do a 70 to 80% depth definition first, then do a little bit of paracentesis here so that we can inject air bubble inside. This air bubble will give us a guide during actual bubble formation intraostomally or a pre-descetic area. You can see the bubble inside here. So once we create a big bubble in the center, these bubbles will move peripherally. You can see the bubble have moved peripherally. So this is a dynamic sign to see that a big bubble is forming in the center. A second indication is having a very clear demarcated circular appearance of this haze in the cornea, which you call, you can see very clear white area. Once these bubbles are periphery, indicating the central part is bulging towards the anterior chamber. So we do a fast removal of anterior stromal thickness, which is around 50%, and see that bubble is still intact. This is appreciable by seeing the peripheral bubbles here. Next step is to make a puncture. As soon as we puncture, the bubble will release and the peripheral bubble will shift to anterior to the middle. So this indicates that you have flattened the bubble which is there. Now we inject a viscoelastic to reform the bubble space. The inner bubbles will shift to periphery. Then we do a 4-quadrant cut off for these anterior stromal layers. So once we have these, you have to be very careful not to damage the descemet, which is a very thin membrane at this stage. You should have a little soft eye at this stage. Don't make too soft or too hard, otherwise they're difficult. And make sure your blades are oriented in such a manner which directly doesn't touch the descemet membrane here. So we can put a donor tissue which is deprived of endothelium, because the patient's endothelium is there and you can suture it subsequently here. So what difference IOCT makes in this surgery, which just you saw it? So here, after we made an initial dissection here, we had done a partial dissection. I know that I have around 20 micron corneal stoma here. Big bubble has formed because the descemet endothelial complex has gone back from the stromal attachment. You can see this is a bubble formation. The next step is to puncture. Once you puncture the stromal layer, the descemet layer comes towards the stroma because the release of pressure here. You can see that once inject a viscoelastic, again the bubble or descemet complex goes back towards the anterior chamber. So this all you can see during your procedure. And once you remove the stroma, again the bubble, the layer will move towards the stroma. This is after completion, because a thin intact descemet endothelial complex, and the stroma has been removed, and you put a graft, and this is well attached. So this is what I want to show, that it gives such a clear orientation of corneal procedure. Today, if you are in a good center where you have an OCT attachment, all cornea procedure has to be done under IOCT guidance. So this is a picture of the same case where you can see a beautiful post-op clear cornea of a dark patient. This is a confocal microscopy of same patient showing the entire layers of cornea is as normal and normal cornea. The other aspect which has changed entirely for us was the endothelial keratoplasty. Every step, right from the incision to descemet scoring to attachment of the dissect, was clearly visible in a very nice manner. So this is a case where a donor cornea is put on artificial chamber. Then we measure the thickness of donor tissue, select the microkeratome according to thickness, so that we leave around 100 microns of stoma behind with the endothelium. So this is the automated microkeratome being done onto the artificial chamber attached tissue. We have taken 500 micron thickness of microkeratome blade. So it all depends on a pre-op thickness of donor cornea. Then you select the proper keratome head so that you achieve a very thin tissue here. You can see here around 100 micron tissue has been left, which is a very good tissue thickness for a dissect surgery nowadays. Once we remove that from the artificial chamber, we punch it from the endothelial side. Subsequently, we will be putting this into the cornea, which is deprived from the diseased endothelium. We'll put this graft inside with the faucet. This is iron-peeling faucet for retina surgery. Thin and long, we pull the graft outside, then pull it inside the anterior chamber. You can see that despite pulling, the graft is not yet fully open. This is visible here. So I'll keep running the fluid a little bit so the graph opens clearly. Once the graph opens, I'll read the hole from here and take out the AC maintainer, inject the air bubble, and see the position subsequently. You can see it's very nicely attached graph. So these things were visible because of IOCT, and we did a study to compare how much time is required to attach this donor lenticule to a stroma. In a case control prospective study, we realized with the intracameral pressure maintained and anterior massaging of the cornea, the graft gets attached in less than 3 minutes. You don't have to pressurize the cornea for 10, 15, 20 minutes because that pressure can knock off the optic nerve function. And subsequently, you have a few signs the graft is well oriented. The outer one should be smaller, inner one should be larger. This is a double ring sign. But if you have IOCT, you can see the acute bevel angle, which can give you the exact location correctness of a donor lenticular tissue as such. This has a role in the modern day endothelial keratoplasty, which is descending membrane endothelial keratoplasty, or DMEK, where we know the orientation inside the antechamber by IOCT. The correct orientation here, this is a reverse orientation, this is the correct orientation, a proper Mostes sign, which can be seen in the IOCT here. So this is my role inside. I have a correct orientation. You can see a correct orientation. Then I'll open it, inject air bubble, and attach the graft. So this is the incorrect orientation. You can see here it is incorrect orientation. I'll flip the entire roll and reattach the graft. So that is what is appreciated. Sometimes you have a complication like a pupillary block. This also gives you a lot of help with IOCT guided surgery can be done in these cases also. And one of the most important aspects of IOCT is doing a repeat procedure in endothelial keratoplasty, both in DSEC and DMEK, because detachment is possible in these cases. Like you can see here, peripheral detachment or DMEK case. You can see this is the area which is being detached or not attached appropriately. So once I know that which is the area attached. I see this IOCT of this particular case. So this is the area which is not attached, the inferior one up to here. Superior is well attached. I'll start in putting a paracentesis here so that the fluid can be taken off and roll opens here and inject bubble from the opposite side. And towards the end, I'll know the graft is well attached. So that's the advantage. This is the anticipal OCT next day of the cases. And other way around is if you look for a difficult case, this is a patient where DALK had been done. Towards the end of surgery, still the DALK and the endothelial complex are not attached. So if you just leave the air bubble and go next day, that graft will be detached, there will be double chamber formation. So we know that the graft is not well attached. We did a stromal puncture here, then did a massage, and subsequently graft got attached. So you avoid the next day procedure for these cases. In all corneal surgeries, the visibility makes dissection better, attachment of lenticule better. Today we would be doing all cornea surgery with IOCT guided, and the outcomes will be much better than a routine surgery in terms of post-op complications. What about cataract surgery? Does it really have a role in a cataract surgery also? Yes, we have done a lot of work in cataract surgery also, especially intumescent wide cataracts, post-polar cataracts, and looking into types of incision, catchment membrane detachment during surgery. That can be easily appreciated in these cases. So this is what the first area of my interest was, to look into what type of dynamics can happen in wide cataracts on the table. Because you can appreciate these pictures by anti-7 OCT also. But IOCT gives an advantage when you make a puncture onto the lens capsule. What happens to the capsule? What happens to the intracapsular cortical matter or fluid which comes out? How much the pressure in the intralenticular can be assessed in these cases. So this new concept gives you an opportunity to see the various types of wide cataract. So we have divided into 4 classical types, though you can have in between category of these cases. So this is type 1, type 2, type 3, type 4. I'll come to them one by one. So let's look into type 1 cataract. So these are normally sinusoidal in the old age group. They have a anterior diffuse elevation of anterior lens capsule. Then you have a hydrated cortical fibers and little bit of intermingled interspaces which are a hypodensity seen in IOCT here. So these cases, as you make a nick in the anterior capsule flap, nothing comes out. And there are no bulge also. So you can do a very nice capsular access in these cases because there is not much of a raised interventricular pressure in these cases in type 1 category. The surgery is very simple. You can do by needle or capsular access forceps. So this is a type 2 category which is normally seen in a slightly younger age group. So if you see here, the image here is classical. You have a little anteriorly convexity of anterior capsule. There is a uniform hydrated lens fiber right across the entire length of lens anatomy. And there are spaces in between and the thick fibers, multiple spaces are there. Let's see what happens after we make a nick here. Despite making a nick here, the pressure doesn't get released because these continuous hydrated fiber doesn't allow the space to be released. So these cases, needle aspiration may not help because you have a thick cortical hydrated fibers. So these require aspiration. See this video here. We'll make a nick. As soon as we make a nick, you can see the entire hill or the tsunami wave is coming out of opening in the capsule here. So immediately we'll put a dispersive viscoelastic so that it maintains the pressure and they make a smaller opening in the capsule. You can see we made a 1 millimeter opening, subsequently use a bimanual aspiration. See the entire hill has gone and the capsule has gone back and cortex has also gone back. You could do a rhexis very comfortably. The idea here is to know what type of picture you have and accordingly plan surgery subsequent. This is type 3 here. You do have a lot of spaces and fibers also, but they are not continuous. So these cases, you might be able to aspirate the fluid and pressure will go down in these cases. Needle aspiration may be possible here. So if you see here, as soon as I make a incision here, there's a release of a milky fluid or a little bit of turbid oily fluid comes out. That will decrease the pressure immediately in such cases. I can make a small rhexis or moderate rhexis in these cases, which will allow emulsification to be done comprehensively. After emulsification, you can further enhance or remodel your rhexis to cover the good area of IOL of around 3.5 millimeter in the periphery here. So that's the advantage of type 3 catheter where you can have a little bit of decreased pressure. You can use either needle aspiration or you can, sometimes you may have to do a bimanual aspiration also. Type 4, you can see a absolutely hydrated cortex here. No fibers are seen. They're all milky fluid. So this is a total loss of a cortical in type 4 cataract. They are towards the Morganian type of cataract. The release of fluid immediately decreases the pressure. And sometimes there's a lot of a disbalance because nucleus is free. Rhexis can also be difficult sometimes in these cases. You require a little bit of putting a viscoelastic inside so the nucleus gives a support to rhexis. So these are various types of wide cataract you saw here, and I told you, you can see 4 types, but in between you have ranges. You see here, this is a little different. With type 3, this is different type of type 3. You have more space here, more fibers. So you can have type 1, type 2 in between type 1, type 2. You can have type 2, type 3. You can have in between cases also. Type 3, type 4, you can have in between the scenarios also. The large range of a scenario can be seen. These pictures you can see in an anti-7 OCT also. You must do anti-7 OCT in difficult cases and plan your surgery accordingly. The chances of damage or excess incompleteness or peripheral extension is much more in type 2 where you have a raised lenticular pressure despite opening the capsule also. Type 4 has liquefied cortex, immediate release of pressure, and rhexis can be done beautifully in these cases. This was our work which got a Best Video Award in American Academy last year. Little bit of posterior polar cataract because people do appreciate difficulty in posterior polar cataract. These are various images. You can see a posterior polar cataract. Depending on the size, density of nucleus, you can, this is open capsule here, which will make a surgery difficult. The pre-op assessment, as I said, you can do anterior OCT that can also picturize the posterior pole. With your microscope, you can see all these pictures very, very classically and decide what type of posterior polar you have in your scenario. This is our recent publication at JCRS on a classification of posterior polar cataract based on an IOCT picture and a dynamic change which happens during the actual procedure in these cases. So we have divided type 1, type 2 and type 3 cases depending on the morphology in these cases. Type 1 here you can see a central polar cataract, which is a disc which is around 2.5 to 3 millimeter. But there is a clear delineation of posterior capsule from this plaque. You can see both here, and these hypodense areas make the clarity of capsule very clear here. So these are cases which are safe during your surgery. And if you look into a type 2 here, periphery is very clear. Central areas, you can't delineate the posterior capsule here. So these are going to be difficult cases. Type 3, you can see here large, thick posterior polar cataract. Nothing is visible beyond this in terms of posterior capsule is concerned, right from center to periphery. So these cases are going to be much difficult and they are much harder nucleus as such. So how do we manage such cases? This is type 1, where you can see a posterior clarity of this thing. In type 1, we do hydro delineation. You can see delineation has been done. This is a nucleus complex. This is epicortical cushion and posterior capsule. But in these cases, we do hydro dissection also, so that surgery becomes faster. You can see this is rexis being done. After rexis, we can see the hydro being done in this particular case. This delineation would happen immediately. You can see the cortical nuclear complex. This is a cortical cushion. After this, we'll do a hydro dissection to separate the entire posterior epinucleus from the posterior capsule. So this is a type of cataract where you can do both posterior hydro dissection and hydro delineation. Once you do a hydro dissection, the surgery becomes simpler and faster, and you can finish these cases very fast. So this is during nucleotomy. In these cases, the piece is intact. You can see after complete removal of the nucleus, the entire epicortical cushion is there. Now I am removing the epicortical cushion from periphery, leaving to the center, and removing the in-block epicortical cushion. You can see intact posterior capsule now, and we will implant the foldable eye in these cases. So this is a type 2 cataract where you saw that delineation is not clear in the middle. In such cases, you need to avoid hydro dissection. You need to do only hydro delineation in these cases. So this is hydro dissection. The hydro delineation has been done. You take out the fluid by decompression so that you don't have enough pressure here. So we'll do now nucleotomy. This is a slightly harder nucleus around grade 3. So we'll be doing a stop and chop technique in this case. See, after completion of nucleotomy, you have a large epicortical cushion here which protects the endothelial posterior capsule. At the end of surgery, clear posterior capsule and we implant eye subsequently. This is a type 3 where you have a larger disc, harder nucleus, nothing visible beyond this disc, where a highest risk of a posterior capsule and dehiscence happening during the surgery. So we do a multiple delineation layer. You can see 1, 2 delineation in this particular case. No hydro dissection to be done in such cases. After we complete the nucleotomy in such cases, we can remove the epinucleus cushion subsequently, and surgery will be complete. So these are a variety of posterior capsules you can see, and in laser refractive cataract surgery also you have OCT attachment, and that can give you an assessment of posterior capsule and these posterior polar cataracts also. I would say in posterior polar cataract, surgery can be simpler. You can decide in which case you can do hydro dissection. So if you have an anti-segment OCT pixelization also, all of you can decide if the posterior capsule is clearly delineated, you can do a hydro dissection and surgery becomes very simple. No point having everything attached towards the end in these cases. If you have type 2, type 3 cases or type 4 which is totally open capsule, you should not do hydro delineation and do a layer by layer surgery in these cases. IOCD really helps the posterior polar cataract in pre-op assessment like this. You can classify 1, 2, 3 types of cataract. And if you are type 1, do both delineation and hydro dissection. If you have a type 3 cases, only delineation to be done in such cases. And always make sure your antechamber is maintained throughout your surgery. When you come out after your phaco, don't let your chamber collapse. Otherwise, the pickup capsule can open up that stage also. The posterior polar cataract, make sure your capsule or the antechamber is pressurized all the time. Never let it decompress suddenly, otherwise you'll have an opening of posterior capsule access. So if you have complication, detect early which is possible in IOCT access. This is our own assessment in cases we compared manual versus femtosecond. And you can see this is a femtosecond incision. You can see a triplanar incision can be done in a femtosecond. While in manual, you can do a uniplanar or biplanar incisions. This is one of the last videos to show that IOCT is so helpful in difficult cases. This is a Fuchs interciliary dystrophy patient where I am doing cataract. Let me go towards the end of surgery. This is the aspiration. I implanted IOL here. Now at this stage, I'm hydrating the wound with the and see after hydration in Fuchs patient, there's a gross detachment of the descent happening in the wound area. If I pressurize from side, I might leave it at this stage because I can't see what has happened. If I take my IOCT cursor toward the central area, I can see the large area of undulating area of descent detachment. Therefore, I'll have to inject an air or a gas and maintain the pressure for 3 to 5 minutes and see the entire thing attached. So this is going to prevent the next day white cataract. This is a helpfulness of IOCT on the table for these cases. This is also helpful in ICL surgeries. You can see in ICL, once we implant, I'll know what is the axis because I would, you can see callisto-guided implantation. And towards the end, after aspiration, you can see what is the bolt of this ICL on the table. So this is a high definition picture. You can see here the bolt is around 500 microns. So that is the advantage of having IOCT during your surgery in these cases. Ocular surface surgery is also very helpful, especially pterygium surgery. You can see this is a surgery where I could assess the entire thing before surgery, and after completion, this is a surgery has been done. I see the smoothness, dissection of entire peripheral cornea, and that's the advantage would be there in a neoplasia surgery also. And putting up also makes simpler. You can see the attachments. There is some limitation, as I said, tracking is difficult sometimes. The metallic instruments makes things invisible, and there's a analysis, especially volumetric analysis with this IOCT attachment is not yet possible, which will be a future thing also. To summarize, I had covered keratoplasty, cataract, refractive procedures, and pediatric cases where examination is so difficult. So if you take the patient under the microscope, under UA, then you can see so many things and your diagnosis may be better. You can plan your subsequent application. Either medical management or surgical management can be done appropriately in these cases. The IOCT has a real boon for all of us. I would say towards the end, we know that technology advancement will happen and technology will drive us to do much better in future also, and they'll continue to develop. Like we have seen from ICC surgery in cataract to femtosecond laser surgery, cornea keratoplasty to a destinal membrane interciliary keratoplasty surgery. Now there will be technology will be driven by artificial intelligence, new devices, new ways to put drugs to improve their penetration to corneas. But I think we are the major force, limitations, not accepting technology in the right time. If you accept the technology in the right time, implement them, you're going to do much better, you're going to do much more innovations, which Dr. Rohit is going to talk about subsequently. Thank you for listening to my talk. Again, towards the end, I would again congratulate the team BHU for doing wonderful work, and hope that we'll be meeting again and again in future and coordinate better in teaching, research, and patient care. Thank you and namaste.
Thank you, sir, for your wonderful talk, and we always need your blessings and support for our development. Sir, there is one question from someone. He wants to know that if he is not having IOCT, then what is your practical tips to do the posterior polar cataract?
I told them also, it's not necessary that you need IOCT. You require an anti-segment OCT or a good slit-term examination. If you do a good slit-term examination also, you can pick all these features. Anti-segment OCT will give you a much more authentic, reproducible picture in your hand. And if you read our article, you can classify these cases beforehand also. So you can know what is going to happen on the table. What should you be doing? Either do hydro or no hydro, or just a delineation. You can just assess by anti-segment OCT only. IOCT is going to help you what is happening during your surgery. Otherwise, your pixelization is beautifully seen in the anti-segment OCT nowadays. So I would suggest all people who are doing posterior polar cataract, they must do an anti-segment OCT apart from doing a good dilated slit lamp examination.
Thank you, sir. Thank you. Our next speaker is Professor Rohit Sethi, sir, who is not only a wonderful surgeon, but a dream mentor for the young generation. Sir, please, Rohit sir.
Thank you. Thank you, Dr. Deepak. Can you hear me?
Yes, sir.
Yes.
Yes, sir.
I would like to congratulate the team BHU, Professor Maurya, Dr. Deepak, Dr. Prashant, Vineet, and everybody in this panel for completing this achievement and also creating such a state-of-art facility. The talk I'm going to give is Future of Ophthalmology that I see. These are my financial interests, where I receive grants for many of this work I've done. This place is written on my wall, this is on my research wall. The most of this place in the languages we've always done in this way. I think Professor Priyal sir explained beautifully about how you have classified, once you get a new technology, instead of just using the technology the way it was supposed to use. I think the last 30 minutes was brilliant talk about how we reclassified everything what has been the gospel truth in the textbooks, classifying your posterior polar, classifying, reclassifying. Virtually, today this microscope may be costly, but I think he set a path for companies, even in Indian companies, to come out with cheaper version of it. I'm sure what I see from Sir's talk is in the next 10 years, every microscope will have an OCT. Like every clinic today has an OCT. It's very difficult to go to a clinic without an OCT. It's become part and parcel of our, it's like having an autorefractometer. I think this is what is going to happen. Why do we always have new innovations? Why do you need to always look at it? It's because the necessity is the mother of all invention. There's a beautiful picture from Heidelberg on 30th year. Come out with an OCT which has a software, a complete picture of the eye, your anterior segment, the posterior retina, the choroid. Such a beautiful image, and this is what is going to be the future. You know, you take one section of it, it's an axial section, it's a corona section, and you know all those. Now it's a complete picture, and you see everything as a whole. And your nucleus, your cortex, your posterior polar, every posterior cortex, everything is there. There are three things. One is your question, you understand your problems, and application. I think both Professor Dogra and Professor Tityal sir explained so beautifully about these three things. I'm just going to give a little summary of what has been already discussed. Coming to the imaging, what I see is the next big thing is not the topography. It's about how you play with your epithelium. Epithelium is nice fitting dress, which covers up everything, and you don't know what is happening in the posterior part. This is new technologies like the MS39 today will look at a completely new dimension of topographies. They dissociate epithelium from the stroma. They bring you an epithelial zernicase, which a lot of refractive surgeons have been using. And these are all our publications on different zernicate platforms on the epithelium itself. You know, everything was an epithelium and the Baumann's. The whole platform of this we published on how each of the layers of epithelium can be studied. For example, I'll tell you, this is an epithelial change. And when you look at, for example, if you're a cataract surgeon, let's look at Professor Tityal sir, he would look at this -1 diopter as a cylinder coming from the corneal stroma. But this 1 diopter is actually from the epithelium. So this is the way the future innovation is, because what happens is this 1 diopter, what you call it as a cylinder, will change once you start using steroid, once you made your incision, once you do a cataract surgery. This is not from your stroma. This is not your K1, K2 axis at all. So what is happening is many of these factors will completely change. For example, this patient is perfect. There's absolutely no cylinder. So that means this patient does not have a cylinder. So imagine how much impact this will have in future of your biometries. in perfecting your SIAs, perfecting your RIOs, perfecting your formulas. And this is what is going to be, for me, the big future of imaging is going to how you integrate epithelium and the Bowmans into your understanding. Unless you do it, I think we're going to be very, very slow on this, on our understanding. We've been looking at corneal nerves. This is one of my favorite areas of interest. I finished close to 16 years of working on confocal microscopy. This was the first equipment I bought in 2004-05, and it's still there. So I have long data of studying corneal nerves, dendritic cells, virtually spent close to 2 decades now. And I compile all my work, I call it as a nirvana study. The nerves impacting refractive surgeries, aberrations, virtually everything, aberration, neuroregeneration, adaptation, everything, what happens in our refractive practice. Let's look at these 3 patients. I will do the same thing like what Professor Titial sir said, not as beautifully as he showed with his videos. There are 3 patients with 3 different types of epithelium. You can see that epithelium are different, and these are patient 1, 2, 3. Let's look at them. Let's look at this. This has got more noise. This is better one. When you do this, the nerves are good here. The nerves are decent, and here poor nerves. And you do a surgery on them. This is what happens. This epithelium is so irregular because the cornea nerves have not healed compared to the heals. And what does it correlate well? To your patient's OSDI scoring. So what is important here is your health of your nerves is the most important in looking at how they heal. And if this healing is better, this patient may have 20/20. All of them have 20/20, but this guy will have a lot of unwanted issues. And that is one of the major factors why we need to look at it. The third layer, which I think what I see, which is not been studied too much, is your Bowman's layer. So when you look at this layer out here, this is maybe 8 to 10 microns. Nobody cares about it, but this has a huge impact in your outcome of your surgery. When you look at carefully here, you can see this is wrinkles. And here, if you see here, it's no wrinkles. And you can see here, again, you can see it wrinkles. So wrinkling is a very important factor in poor quality of vision, especially when we are going towards the smile-based surgeries. What happens when you have wrinkles? Your vision is scattered. When you don't have wrinkles, you have a perfect vision. So a simple Bowman's layer, which many of us would not pay attention, would be the major focus of your finer quality of vision of the future. And earlier, we would not have all these features to see. Now we have beautiful technologies which can pick up this wrinkles, which you see here, which could probably be the factor why this patient has scattering of light, and we just tell them, give some lubricant and ask them to come back after some times. The biomechanics, a lot of things has been said. We have always, looking at the strength of the corneas. We did this work on predictive modeling when we're using the biomechanics. These are all predictive. That means even before the surgery was done, we would predict. The dotted lines is the predicted ones. The real lines are the ones, if you look at these kind of lines, they are all the actual what happened pre and post surgeries. We have built a very beautiful software which will be used on the Oculus platform, where you have to enter the patient's power and the Corvis data and the Pentacam. The machine will tell you which procedures, the SMILE, PRK or LASIK, how much of it will reduce the biomechanics, and you can choose whichever has the least amount of damage. For example, the patient X, should I do a SMILE on him, LASIK on him, or a PRK? So we enter all the data with biomechanics. This is based on an artificial intelligence model, and this is completely built. And this software is just after 2 years, we just finished with testing this. And this will really tell you you don't have to worry about the mathematical modeling part of it, is already inbuilt into this. So this is going to be the future. For example, if this is your dotted line, each patient, it will tell you what is the percentage of weakness even before you do the procedure. So any refractive surgeon can use this and then decide which one would be the safest limit for me. And that's what is going to happen. Coming to imaging, this is how a collagen imaging is, and you can see the keratoconus is completely different. And there are different topographies. There's always a challenge of which topography is normal, which is not normal. So what we thought is, in the past we had looked at, in the immunohistochemistry, we had looked at the collagen, and now we built our own polarization sensitivity, and we started looking at collagen. This is the collagen imaging, basically the normal and the abnormal collagen, and this is how it looks. And you can see that this is an abnormal one. You can see there is a change out here, and this is a normal one. So they are all strong. These fibers in the periphery, which are yellow colors, means they're stronger, and the central is blue, which means they're good. Once you lose signals here, that means there is some signal changes. The collagen may not be very strong out there. So imaging collagen is going to be the next big thing. And in the imaging, they're controlling the aberrations, understanding the aberrations from the lens to epithelium to cornea is a very, very important factor. And this is a simple thing about how the, we understand the accommodation also. And what we're trying to do is, once you understand the aberrations, I feel the future I see is not the aberrometers we use. There'll be a time when we'll be using better aberrometers like adaptive optics, where you can customize the aberrations, and you can actually, I just skip a few slides, and I'll just skip to this slide. And what I feel is we can customize the amount of aberrations, and actually you can fit into your patients like a phoropter. And these aberrations can actually be used, what we get, these aberrations, what the patient likes or dislikes, can actually be loaded on to the treatment planning. Now at this point of time, some extent Schwinn platform does allow what is in, these are all not the aberrations which are treated, so I can knock off what I want to treat, what I don't want to treat. So I mean, it looks complex for this talk here, but what I'm trying to say is, you do not have to knock down every aberration in the book, because they are all, some of them are necessary, and how do you know which one is useful or not? By using the adaptive optics. And this is how we are getting the data. This is exactly a keratoconus patient. You can see how by taming the aberration, we're actually getting the kind of response we want. So this is how it's going to be using adaptive optics. You can look at customized treatment, different IOLs, KPC management, and complex corneal platforms. There are a lot of new platforms coming. The ray tracing is from Alcon, is going to be the next big thing which is going to come out. Customized ablation, SMILE technologies, we all know, and different companies are coming out with their own versions of SMILE. There's a lot of insight into molecular markers from the tears. This has been my area of work. They're like, they call the biomarkers. And what I feel is this, how, you can extract the molecules, cytokines. I mean, a lot of things have been, because of COVID, we hear a lot of things at this point of time. Most of my work has happened from this Shermer strip, which everything gets preserved. We store it in -80 degrees. This is one of the largest biorepositories in the world, with thousands of samples there. This is the end of my OT list. When you can see, this is epithelium, tears, wash, Shermer strips. Virtually everything gets collected, stored in -80 degrees. And whenever we want to, we just take it out, study those molecular pathways. And I'm not going too deep into this, but what I'm trying to say is all this helps to understand the etiopathogenesis of a disease. The role of microbiome is a huge impact in the future. Now, even we know that diabetes also could be a factor. I worked in keratoconus. I'm sure even glaucoma tomorrow, many bacteria could be triggering of a disease. And they could be potential cause of many things, and therapeutics will be an important factor. Imagine tomorrow if I tell you that I can treat keratoconus or dry eye with an antibacterial drug. Today you will laugh at me. But what I'm saying is, tomorrow, these are the unique bacteria which are there in your ocular surface, which are creating a lot of change. They could be creating a change to dryness. They could be creating a change to dry eye. Today we don't know. But as we move on, I think what I feel is you will have a lot of these bacteria driving different disease. And you'll be surprised that they could be even driving a disease like dry eye or glaucoma. But that's what we need to find out. As we move on, we need to bring all this to the labs, all that we discussed to the labs, to the final thing, so to the clinics. And then, what we're trying to do is we're trying to build a kit which has been delayed. Otherwise, by now we should have had a prototype, and then we should have commercialized it. It all got delayed by a year or more, I don't know. And eventually it will happen where most of in the rooms, people can look at these kits, take the tears or aqueous, and then these are the kits you put the tears, and if you have a reader, it will tell you what is happening and what your molecules have. This is not only for the dry eye. We have worked on VEGF, ROPs, many things, and many ocular surface can be treated with this. Everything has to move from molecules to genes, or genes to molecules. And because, see, whatever molecular pathways you have, it's all coming from your genes and epigenetics. So we worked a lot on building. This took around 4.5 to 5 years to build a very advanced facility on gene therapy. This is not just for the eye, even muscular dystrophies. There's a huge amount of genetic disorders which could be treated eventually, what I see. But I see a lot of hope in many conditions, not only in retina, even corneal dystrophies. And, I'll just skip these slides, and you can see that this slide, what it means is when you have less of collagen, your treatment is not as effective as having a lot of collagen in a post-crosslink eyes. That means your collagen and lysoloxidase, all these factors play a very important role. And this is a model we created about the gene therapy in the lab for collagen-based disorders. And we did the first testing we have our own animal lab. This is something we set up during the COVID time. Fortunately, these are all the OCTs for the mouse, rabbits, and you can even do it on even in a python's eyes if you want to try something. And these tell us, we've been trying out a lot of these models on these things to see if we can get a good results and trying out these things. Finally, you need big data and you need AI-based systems. And for example, we are trying to compile virtually everything together into an AI-based platforms. AI need to have everything: imaging, demographies, molecules. So if you have one, the AI is not as smart as having everything, but it takes a really long time. I would say years. If I start today, probably I'll be the first prototype of all this would probably be ready in 2025 or 2026. Tremendous amount of patience, both from our side and also people who keep asking us. I did see it 5 years back, you're still nowhere. This is very important because the future we see does not happen overnight. The future we see takes a long time. Whatever I've just showed now, the work was started in 2010 or 2011, some even 2012. So it is a very long process, and if you have a really patience, only then it reaches that stage. And this is what my dream is, to have a complete AI-based software where you have everything fit into this, and it will tell you exactly for any disease, for keratoconus, LASIK, glaucoma. But we are there. I would say we are just around 10 to 50. This is a real-time software. This is not a graphics. This software is ready and you can actually fill in a lot of data, but eventually I want to add everything to it. Maybe in 4-5 years, this will be a reality. This will be part of our life. And I believe that the statement which I feel I want to end with this is when I started off with the future I see, I want to end this talk by saying this: the future is not an extension of your past. So if you expect that your future is just going to what it is today, then I don't think it's going to work. This is exactly what Professor Tityal sir said, and he showed that it may look fancy today, but your future is not an extension of what it is fancy. It is going to be reality tomorrow, and this is exactly what I wanted to share here. I just tried to compile everything. It was not a very in-depth presentation. I just compiled everything, what could be the future, what I see. Thank you.
Thank you, sir, for your wonderful talk. And we really feel honor and privileged to have you, Tetial sir and Dogra sir today on our Foundation Day function. Professor M.K. Singh, sir.
Thank you, Dr. Deepak.
Sir,
we really enjoyed this webinar, and I think all the participants must have been immensely benefited by the lectures, the innovative lectures given by all our three experts, and must have opened our eyes and have broadened the horizons of our knowledge. Thank you for joining us on this wonderful day and making it a great success. My thanks to everyone, to the speakers as well as to the participants. Thank you, sir.
Okay, Moria, sir.
म्यूटेड है, म्यूटेड.
Okay, Moria, sir.
Thank you very much, sir, for wonderful talk.
Moria, sir.
आवाज नहीं आ रही.
मोरे सर, आपकी आवाज नहीं आ रही है. Moria, sir, your voice is not coming.
It's my privilege to propose both our thanks on the second Foundation Day of the RIO. First of all, I would like to express my sincere gratitude and thanks to our chief guest, Professor Vikas Sir, Director, Banaras University. He has blessed us and graced this function with his gracious presence. He always inspires us to develop new avenues for the operation of our department. And actually, our department upgraded to RIO due to his blessings and guidance. Thank you very much, sir. Our guest speaker of this webinar, the Professor Mangat Ram Dogra, he enlightened us by his scientific pearls of wisdom on the retinopathy of prematurity. Thank you very much, sir. And the next guest speaker, Professor Jeevan Itial, he is a very eminent speaker and he used to come in our department whenever we have requested him. He has spoken on the intraoperative OCT guided anterior segment surgery, which is essential nowadays during anterior segment surgery for further confirmation of surgical set. Thank you very much, sir, for this lucid presentations of newly technique and technology. Our next guest speaker, Professor Rohit Sethi, he has delivered his talk on the future of ophthalmology. He has guided and inspired us on the newer advancement in his field of ophthalmology. Thank you very much, sir, for this excellent presentation. Professor M.K. Singh, Chief of RIO and Deans of Students of Banaras University. He is always guiding us for the development of our institute, and I hope under his leadership, our RIO will attain a greater height of glory very soon. Our beloved faculty member, Professor E.P. Singh, Professor Prashant Bhushan, Dr. R.P. Maurya, especially Dr. Deepak Mishra, work hard to make this webinar a great success. I also congratulate to all the residents and senior residents and other staff of the department to make for their consistent work, consistent hard work to make this conference of a great success. I also thankful to all the members of the pharma into Indore Pharma for their helping in for the success of this webinar. I thank you everyone with my heart and my best wishes to all who have participated in this webinar. Thank you everyone.
Thank you, sir. Raman, are we offline?
Yes.
Okay. Thank you, sir. सर
Thank you, sir. डॉक्टर
सर एक स्टोरी मुझे बतानी है सर. जब मैं सर RIO के काम के लिए गया था तो आई थिंक सर स्केरिस का एनुअल कॉन्फ्रेंस था जिसमें कि दीपक तुम्हारा RIO हमने सैंक्शन कर दिया है. There was a file. Rohit sir, we have MOU with AIMS that all our things, whatever we are going, since BHU is going to be AIMS-like institution, so our mentor institution is AIMS. For that, I visited twice in the RPC to make all the project and financial and everything. And one day we are in search what we are going and how, what are things are going on. And suddenly Tetial sir picked me and said, on file ho gaya, tu baak.
And he will continue to support us in future too.
Always, always.
And Rohit sir, we want to do some interdepartmental research with your institute too. Kindly guide us how we can do our good things.
Sure.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
नहीं, मुझे तो बहुत अच्छा लगा to be with you people again on this particular occasion. And
Yes,
तो
sir.
पहले बहुत है, लेकिन I think the future, as Rohit nicely pointed out, future has to be, innovating yourself. So unless you innovate yourself, nothing is going to come. आप सोचोगे तब चीजें आएंगी. तो आपने सोचा RIO हो गया, तो RIO को इंस्टीट्यूट बनाओ, और उसके आगे जो है, जैसे आपने रोहित को सुना, you must have a research department in your block.
Yes.
Which people are missed out. I always talk about what we have missed out. You people are now starting. So एक research block पहले से बनाना शुरू कर दो, and write a various projects so that you can make a center of excellence in one particular area. So pick up one, Abhi said. And Rohit said it might take another 10 years or 15 years to get something. And in government sector, it is much more difficult. But if you persist, you will definitely get it.
Like average time to concept, to conceive and to look at the 6 to 7 years.
Yeah.
And whatever I show is 6 to 7 years. In 7 years time, whatever I'm doing today, I will show it in 7 years down the lane. I mean, me or one of us will show. So if you don't do it, there will be nothing in 7 years to show.
Yeah, that is true.
Certainly. This is really innovation.
Like, people, they have to be people who can, give you some sort of a thoughts. कभी-कभी किसी से बात करोगे, किसी को सुनोगे, देखोगे, तो आपके दिमाग में thoughts आते हैं. And that makes you work. And if you are in a position, especially in the government sector, if you are in a position to implement, जो आपके chief साहब हैं, के सिंह जी, if you have a young people, उनको आप दौड़ाओ, उनसे काम कराओ.
जी,
work out.
Certainly, sir.
Yeah. And Dr. Dogra is there. I am always there. हम तो साथ घूमते रहते हैं. We have been instrumental in Patna RIO also.
Yes.
So we have become now, experienced people in that regard. But
I think I agree absolutely what has been already said by Dr. Tachal as well as Dr. Rohit Shetty. I think how it becomes, you see, government, we work for government. We are also like you, not sitting in the FX center or something which I think Rohit Shetty has developed is absolutely beyond imagination, and he needs to be sort of really, really appreciated for that. But if you have a team approach, and at the same time, once you are just growing, it's 2 years old, you need to develop subspecialties. You need to give chance to the younger people. And if you let them work independently, they will show the results. If you don't let them and they are just suppressed and the people sitting over them, then it won't work. But that is what is happening in government institutions across mostly, and that is what we have seen. But if we let, and that is what was the culture in our, you see, we were one small floor department. Because I'm telling you, our RIO, Pramod Gupta took over. I think he gave one area to everybody, and he never even asked them to do anything else. But he wanted that you concentrate on that. You want to go anywhere, you want to get trained, you want more things done than that. So what happens? You see, if you train young people, they would definitely bring the result, and let them work. Let them work. That is what I would say.
बहुत सही कहा डॉक्टर डोगरा कि जो है आपकी यंगर जनरेशन है जो आपका नाम जो है हमेशा आगे रखेंगे. And if you don't give opportunity to young people, you are not going to be remembered subsequently. So ये बहुत जरूरी है. Like sometimes we feel the younger people are not working, or they are working in different direction, not respecting the place. That is also true. I also feel we have a lot of young people whom, given an opportunity, they are wonderful people. They have a lot of resources also and thinking. But sometimes they don't give respect to the institution where everything is provided by the institute. They don't provide respect to the system. Then things go haywire. If young people, they respect the system, I don't think any senior will prevent them to do any work. It is the coordination between the team. And young people, they must respect the system. Because the system, they are there. If they respect the system, system will come up. System will come up. So that is my always saying to my young people. Even don't respect me, but respect your system or your institute. You'll be better. So that is what is important. Your institution, you have to, your roots, you have to be there. Otherwise, very difficult. तो जो भी है बहुत बहुत मुबारक हो भैया. हर साल आते रहो और हमें भी बुलाते रहो.
आप लोगों का सहयोग मिलेगा. We will continue to have this practice.
We three like to be there next year so that we can all go for a eating puja. That
yes.
You like to be there
physically together. Physically together, sir.
आप तो आगे डोगरा सर लास्ट टाइम नहीं आ पाए थे और रोहित सर का 2 बार प्रोग्राम कैंसिल हो चुका है. हम लोगों ने
हम लोग सबको
वर्क समवेयर.
दीपक हम लोग सब लोगों को सर लोगों को साथ में बुलाएंगे. दिस इज प्रॉमिस टू देम.
One of the best evening aarti is in the Banaras. You enjoy that beautifully sitting in the boat and you enjoy. Oh, that's wonderful.
Yes.
And the people in Banaras are wonderful people,
Thank you, sir.
मुझे तो पता नहीं कितने टिकट हुए आते हुए. रोहित कह रहा ना, it takes 10 years to build up research. So I built up 10-year relationship with these people.
Yes.
And with Professor M.K. Singh, we have been together in many places, right from Nepal to so many places. We enjoyed being together. Deepak to apna hi bachcha hai.
Next year we'll definitely come.
Bas. Let's have all be together. मुझे पता नहीं डॉक्टर डोगरा फ्री होंगे कि नहीं होंगे. अब तो प्राइवेट सेटअप में है.
I'm totally free. I'm a free bird now.
बनारस के लिए जरूर फ्री होंगे. बनारस के लिए जरूर फ्री होंगे.
Okay, wish you all the best. That faculty. See you very soon.
Thank you all, sir, for making this evening very wonderful. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir. Namaste, sir.
Bye.
Thank you, Deepak.
Thank you, sir.
Thank you, Deepak.
Thank you. Namaste, sir. Namaskar. Thank you.
Maurya ji, thank you.
Thank you, sir. Namaste.
Namaste.